Yeah, FRESCO-2 is a clinical trial that's specifically for metastatic colorectal carcinoma patients that had previously received all standard lines of therapy, largely irinotecan, 5-FU oxaliplatin-based therapy, and they may have been exposed to prior TAS-102 or trifluridine tipiracil, as well as regorafenib. And this was basically a randomized study. It was an international study that was conducted outside of China because there was originally a trial previously in China called FRESCO that showed benefit for fruquintinib in the refractory patient population. So FRESCO-2 basically was conducted to validate those earlier findings, but also to make it more applicable to a very generalized patient population. So patients were randomized in a 2-to-1 fashion to fruquintinib versus placebo, and the primary endpoint was overall survival. And the median number of lines of prior therapy was 4 prior lines of therapy for the majority of patients. And the majority of patients had received prior bevacizumab in our analysis greater than 90%. And we were able to fulfill our primary endpoint in this refractory patient population. It's very important to keep in mind that what fruquintinib is basically it is a tyrosine kinase inhibitor that's very selective for VEGF receptors 1, 2, and 3. So it's an oral agent. And as a result, it's convenient for patients because it is an oral agent. And they were able to fulfill, or we were able to fulfill our primary endpoint with all the patients that were enrolled internationally, with a median overall survival of 7.4 months versus 4.8 months, which was for the placebo arm. We did have placebo as the control arm because there is no other standard of care when we conducted the trial at that time, other than TAS-102 plus and regorafenib. And so since we allowed all prior lines of therapies, it seemed very reasonable to have a placebo arm at that time. Also, we were able to fulfill our progression-free survival endpoint, which was a secondary endpoint as well, of 3.7 months versus 1.8 months. And so when you look at the primary endpoint of overall survival, our hazard ratio was 0.66, meaning there was a 34% increased chance of overall survival if you had been provided fruquintinib versus placebo. These are not unique to this drug, so I think it's very, very clear. I mean, hypertension is a very known side effect of any anti-VEGF agent, so any anti-vascular endothelial growth factor agent. And so the one that most people are familiar with is bevacizumab, which specifically blocks VEGF-A, and the most common side effect is hypertension. The same thing here. About a third of patients, about 29%, developed hypertension, and we just treat it with any other hypertensive medications. We always encourage our patients to follow up with the primary care physician, at least I do in my practice. And honestly, the majority of patients already have a primary care physician who's likely already following them for hypertension. So we just make sure that their blood pressure is well controlled. Regarding some of the other toxicities, these were reported in the original trial design, so they were not necessarily selective, but really just following it long-term and really focusing on the potential adverse toxicities, because the issue is that you have 3 different drugs that are currently approved in the United States in the third-line setting. You could have TAS-102 plus bevacizumab, which was a trial specifically completed in the third-line setting. It didn't allow greater than more than 2 prior lines of therapy. In that trial, they also were able to fulfill their primary endpoint. And then regorafenib, which is a multi-targeted tyrosine kinase inhibitor, also has already been approved many years now for the same setting. So you basically have 3 different drugs all approved in the third-line setting. And the issue is that I always discuss with my patients is they have different toxicities. So TAS-102 can result in myelosuppression. Regorafenib can result in hypertension as well as hand, foot, skin reaction. And here fruquintinib basically can get some symptoms similar to hand-foot skin syndrome, but also not as severe as hand-foot skin reaction that's commonly seen with regorafenib. And then hypothyroidism, uh, once again, it's not an uncommon toxicity for our patient population. And we just check thyroid tests, and if it needs to be addressed, it's addressed by the patient's primary care physician. It's very, very similar. So hypertension for any is the most common adverse event for any anti-VEGF agent. That's almost a given for this class of drugs. And then in regards to the hand-foot skin reaction, as mentioned earlier, that's a little bit more, it's reportedly more severe with regorafenib just because it can cause a hand-foot skin reaction, which can result in callus formation. This is not necessarily to that extent, but it is a little bit different than hand-foot skin syndrome that is commonly seen with 5-FU-based therapy. So you can get redness and you can have discomfort, but it won't necessarily result in callus formation. I don't think the safety profile will have any impact on whether or not an individual will not, when you think about a safety profile, as I mentioned, when I talk about my patients, they all have different toxicities. It's a matter of discussion with the patient. I think the advantage of this agent for some patients is that they don't have to go in for their bevacizumab. So as mentioned earlier, TAS-102 plus bevacizumab is also an available standard of care, but that still requires you to go in for your bevacizumab every 2 weeks. And so regorafenib and fruquintinib being agents that are effective on their own in regards to overall survival, it's an advantage because it's an oral agent. I don't think these toxicities, as mentioned for this drug, are anything that cannot be conquered with good patient communication and provider communication. Once again, this is not anything unique. So these are, every time you go in for your chemotherapy, people have got their blood pressure checked already. So it's not anything that's going out of the ordinary. And hopefully they do examine their patients. So it's pretty evident if the patient has PPE. Really, this is nothing unique because we all commonly look at the hands and feet anyways when patients are provided 5-FU-based therapy, which is in earlier lines of treatment for metastatic disease. So these toxicities I don't think are any more unique than some of the other drugs that we've been providing our patient population. No, I would just say from a practical viewpoint, if for some reason the hand-foot skin reaction, despite the various emollients that we use and all the other, it's pretty much the standard treatment that we would use for hand-foot skin syndrome with like Utterly cream or any of those other heavy emollients. The other thing is if you need to consider a dose reduction, it's not unreasonable to go down to 4 milligrams. That's not unheard of if needed. But that is just based upon my own personal experience.